So tonight we're going to cover two different chapters, chapter 24 and 25. So the first chapter we're going to cover is trauma overview, followed by the bleeding chapter. These should be pretty painless. All right, so again, in the National EMS Education Standard Competencies for trauma, really it's just based on assessment findings for the acutely injured patient. But let me get into more of the trauma pathophysiology and assessment along with management of the trauma patient, looking at the trauma score, rapid transport destination issues as well, and transport modes. So kind of learning what level 1 versus level 2 versus level 3 trauma centers are in your critical access hospitals as well, to kind of see where your patients really should be transported to based upon the mechanism of injury and the injuries that you currently have with you. How to recognize multi-system trauma. Keep in mind that multi-system is not just multiple broken bones. It's different systems in the body, whether it be integumentary to respiratory to cardiac, musculoskeletal, things like that. So that's kind of the multi-system trauma that we're going to be covering tonight as well. Pathophysiology, assessment, and management of the multi-system trauma, and also blast injuries as well. So for people younger than age 44, traumatic injuries are the leading cause of death in the United States. Traumatic injuries occur as a result of physical forces applied to the body, and medical emergencies occur from an illness or condition not caused by an outside force. We respond to a lot of traumatic emergencies, whether it be a fall, to motor vehicle accident, to an industrial type accident, to even an agricultural type issue as well. So we respond to multiple different types of traumatic emergencies. Just keep in mind that some of the traumatic emergencies that have occurred also may be the cause of an underlying medical condition. So just because they fell off a ladder does not mean it's necessarily just trauma. It could have been something that medically caused that patient to fall. So you got to look at everything as a whole when you do your assessments, as you can see here. The index of suspicion is your awareness and concern for potentially serious underlying and unseen injuries. So looking at that mechanism, the patient falling 10 feet onto the ground, onto their back or onto their side, think about the internal organs and the other parts of the body that could have potentially gotten injured in that fall, not other than just the obvious what you can see for like deformities or things like that. So could something else be going on internally as well as externally? So we talk about energy and trauma. So traumatic injuries occur when the body's tissues are exposed to energy levels beyond their tolerance. So as we're falling down about 10, 15, 20 feet, we're building up a lot of energy and force. So the mechanism of injury is the way traumatic injuries actually occur. So we're going to describe the forces acting on the body that cause these injuries here in a second. There are three concepts of energy: there's potential, kinetic, and energy of work. So with these here, energy can neither create nor destroyed, but can only be converted or transformed. And we'll talk more about that in the motor vehicle accidents and how we had different impacts throughout that system and as far as energy goes with that. Let's not black out the screen. So work is a force of acting over a distance. So if we have like a motor vehicle going at a certain speed, we'll get to that in a minute though, just kind of keep that kind of stuff in mind. Forces that bend, pull, or compress tissues beyond their inherent limits result in the work that causes the injury. So if we have a motor vehicle accident, car versus tree, there's three different impacts that occur during that, and this talks about the forces that are there. So if we stop and hit a tree suddenly head on, right, we have the impact of the vehicle, we have the body, the human body itself impacting an object, and the internal organs impacting inside. So we have three different impacts that occur when we have these types of forces that are there. So whether it compresses the tissue, so if you have like a tree that falls on top of somebody, we have that compression. So it's a force that your body can no longer tolerate, causing a fracture or some kind of internal bleed of some sort. Or if we have a patient that's being pulled in two different directions, and one of those things you might see would be like suicidal attempts or hangings, where we have a rope around neck, patient jumps out window, that force continues and wants to go down. We have a stopping force that kind of pulls and it causes that distracting type of injury. Or if we have certain bends like hyperextension or hyperflexion that can cause more injuries. So think of the spinal cord, for example, with the bending forces. If you take your head and you push it down to your chin, okay, to a certain point, it doesn't hurt. But if you take your hand and you put it in the back of your head and you push down a little bit farther, you start feeling that pain, that hyperflexion coming down. Okay, that's a force beyond what the normal body can take. Same thing with hyperextension. When you're putting the head backwards, leaning back, trying to look behind, and you take your thumbs or your hand and push them up underneath your chin and keep pushing back and back and back. It causes more pain, which would be more of your hyperextension. So you might see forces like this in your diving injuries as well, when you have head-first entries and they hit and cause compression and or hyperextension or flexion, depending on how the head hits, on that cervical spine, causing it to burst. So think of the different forces that are actually there. So kinetic energy is the energy of a moving object. So kinetic energy equals half the mass times velocity squared. So potential energy, that is a product of mass, force of gravity, and height, mostly associated with energy of falling objects, right? So as it's coming down faster, okay, for a longer period of time, it picks up more velocity, more speed, causing more damage. So think about motor vehicle accidents, right? If you're traveling at 60 miles an hour into a tree versus traveling at 10 miles an hour into a tree. Another thing to think about as well is falling off a step stool, hitting the ground, versus falling off a second-story roof, which is 20 to 25 feet coming down to the ground, right? So you have that mass and velocity building up that kinetic energy to actually hit an object that stops you. So think about it as far as the energy and the trauma goes. The different MOIs produce many types of injuries as well. MOIs being a mechanism of injuries. And then we have non-significant injuries, or injuries to an isolated body part, or a fall without the loss of consciousness. So if we have an object that falls like a tree, for example, that falls down and hits your leg, we have an isolated body part that's injured. They mentioned non-significant, but again, femur fractures can hold up to 750 mLs of blood per femur. So with that being said, you really need to be careful in regards to how we stabilize these patients, and which is why we're going to talk about femur fractures and bleeding on the next chapter. Significant injuries are injuries to more than one body system itself. This would be your multisystem trauma. So if we have a laceration or a stabbing, so entering through the integumentary system, the skin, going into your organs, all right? So this could be something with multi-system. Head trauma as well, causing, kind of like a swelling to the brain in your neurological system, but also having a fracture somewhere else. So multi-systems being injured. So a lot of things could be the fall from height. So what we look for is greater than 2 times the height of a patient would be considered a significant fall. So if you're 6 feet tall and you have a fall 12 feet or higher, they consider that a significant injury because it's more than twice the height of a patient. Motor vehicle accidents, motorcycle crashes, obviously motor vehicle itself, seatbelts, obviously they save lives and everything else. Got to keep this in mind that we're seeing a lot of accidents where you walk up to the scene and you're like, oh crap, that patient should be really sick or really injured. And then they get out of the car and they're like walking around with no injury. Just vehicle design. It helps with that. But there's still a mechanism of injury there, even though vehicles are designed to crumple now versus vehicles of the late ages. But motorcycle crashes being completely different, though, because there's nothing to protect them. So you got to consider the mechanism of injury, and if they had hit an object up and over the handlebars, you got to consider, pelvic fractures, femur fractures. If they're not wearing a helmet, head trauma. Another one would be car versus pedestrian or bicycle. and looking at different injury patterns. So something to look at when you have a car versus pedestrian is kids versus adults. Adults are more apt to turn away and hide, turning away from the vehicle, versus a child who will actually turn towards the vehicle because they don't know what to do. So if you have a child versus motor vehicle, you're more apt to have a more head-on front, stomach, abdomen, chest, head facial trauma versus an adult that turns to the back, where you might have more of a spinal injury or things like that. So something to think about. Gunshot wounds, obviously entry and exit. We always want to make sure we're looking for the entry point, obviously, if there was an exit point. If there's not an exit point, then the bullet's still lodged somewhere inside the body itself. So you got to consider that as well. And obviously stabbings, depending on the type of blade that goes in or whatnot. Blunt and penetrating trauma. So obviously blunt trauma is a result of a force to the body that causes injury without penetrating the soft tissues. So think of an object striking like a baseball bat to the head or a baseball bat to the arm. A penetrating trauma causes injuries by objects that pierce and penetrate the surface of the body, which would be your integumentary system, of something actually going through. Either type may occur from a variety of mechanisms of injuries, whether it be a fall onto rebar versus a street fight, stabbing to, and then you can think of that would penetrate the body itself, versus the blunt traumas that we're going to see from more like falls, if they don't land on rebar, obviously falls to the ground and strikes to the ground or strikes from another object. Now, if we have a penetrating type trauma and the object is still in there, then we need to take a look at. Hold on one second. All right, sorry about that. I'm back. All right, Charles, I got your message for that too. All right. So obviously, blunt trauma obviously results from an object making contact with the body. We talked about blunt trauma a little bit already with motor vehicle crashes, motorcycle crashes. Even if you're in a lakes type region, you can still have blunt force trauma even from people that are water skiing, kneeboarding, whatever, based upon how fast they're going and that velocity that's there, and striking even open water can cause a lot of blunt force trauma as well. So be alert to skin discoloration and pain, because we see skin discoloration that could very well be bleeding under the skin or causing a hematoma and things like that, or just pain itself based upon a rapid trauma assessment and palpating. You also want to maintain a high index of suspicion for hidden injuries as well. So just because we have a let's say a femur fracture that causes significant amount of pain, doesn't mean they have pain elsewhere. It just means that that pain that's currently there with the femur is much more intense than another potential injury, which is why we got to maintain that high index of suspicion for those hidden injuries that are there, which is why it's so important to get that rapid trauma assessment in. And when you're in the back of the ambulance, do more of your detailed assessment head to toe to find any kind of potential hidden injuries that are actually located there. But utilize the mechanism of injury as well to determine where these injuries potentially could be. So vehicular crashes, motor vehicle crashes are classified as frontal, rear end, lateral, rollovers, and rotational. The principal difference is the direction of the force of the impact, whether it be head-on collisions, rear-end collisions. Things with rear-end collisions you got to think about as well are going to be more like whiplash or the contra coupe injuries of the brain. And kind of going back to A&P stuff with this, remember that the brain kind of sits in water, okay? So if you were to take like a walnut and put it inside of a water bottle and you were to shake it back and forth, okay, that's kind of what your brain is doing when you have a contra coupe injury, because you're causing it to go front and back multiple times, causing contusions inside your frontal lobe and occipital lobe, which then in turn can cause a head injury, and you got to look for the signs and symptoms of that. The principal difference is the direction of the force of impact. So obviously rollovers and then kind of rotational spin. So you got to be careful of those rotationals and those lateral impacts or those side impacts, because keep in mind, remember your aorta. We talked about aortic shearing a couple classes ago. If you have a significant side impact and you have a patient that's sitting there seatbelted or even non-seatbelted, that impact alone can cause your aorta to actually shift and cause it to dissect. Remember that can cause significant bleeding, and you can bleed out within 90 seconds with that. So taking patients out of vehicles after they've had a rotational or a lateral type impact, you need to be very careful. Even though it's critical, just keep that kind of stuff in mind of rotating the patients to get them out. So to kind of go over that a little bit more, if you have lateral impacts, sometimes it's just as easy to take the roof off a vehicle and go through a rapid extrication that way and taking them straight out versus making those twisting motions. I mean, keep in mind, the vehicle's already totaled, so taking the roof off, making it convertible is not a bad thing. So as you can see here, a crash consists of 3 different collisions, which we already talked about. Car against another object, well, I should say not collisions, that's impacts. So a crash consists of 3 collisions. There's car against another car, tree, or an object. So by assessing the vehicle, you can often determine the mechanism of injury. So this goes back to the class. What do you guys think you would see if you had, let's say, a driver and a passenger unbelted in this vehicle? What would you guys think?
That they'd be tossed around.
Okay.
Possible ejection.
So we have the head-on collision, right, into the pole. What else would you look at for this vehicle to kind of determine mechanism of injury, other than being tossed around? I got Charles saying ejection. Absolutely, take a look at that. Go ahead.
See if there's any marks from like their head hitting the windshields.
Okay, so starring or spidering of the windshield, right? And as you're looking at it, for the starring or spidering, keep in mind that you're looking for hair or skin chunks. As well. What about inside the patient compartment? What are some things you can look for indicators of chest trauma on the driver? Oh, then obviously markings on the chest. So I got Charles saying the steering wheel. Absolutely. Looking at the steering column to see if it's bent.
See if there's any airbags.
Yeah, airbag deployment. Yep, so looking for airbag deployments. And you got to also keep in mind as well that when you're assessing these patients in these vehicles, that there are multiple locations that airbags can be, right? From the seat to where the knees are, to the steering wheel, to curtain airbags. They're everywhere in vehicles now. So kind of a side point to this, when you are assessing patients still in a vehicle, please make sure that the battery has been disconnected. But if it hasn't, then just keep your head and your body clear of where airbags are. There are some pretty interesting, or actually interesting is probably not a good word to be using, pretty significant videos that are out there of firefighters getting hurt by airbags. So you got to keep this kind of stuff in mind and how fast they come out of the vehicles. You know, up to like 300 plus miles an hour when they detonate. And also they are very hot as well. So just keep this stuff in mind when you are assessing your patients in the vehicle. This one here, obviously, be a front end impact. And what they did is they really opened up this door to get this patient out, taking out the B post as well. So a passenger against the interior of the car. So think of the second impact, remember? So the first impact is striking an object. Second impact would be the body, the human, hitting the vehicle itself. So common passenger injuries would include lower extremity fractures, flail chest, and head trauma. So just looking at this picture alone, that's what I'm seeing. Okay. I'm looking at driver sitting in the vehicle. Steering wheel may or may not be bent. I really can't tell looking at the picture that's here, though. But there is some damage underneath. Now, that could have been either from the knees going into the dashboard, or it could have been from the impact itself. Either way, there was forward motion that stopped this patient, the vehicle, I should say, and that patient kept going forward. So if they have the potential for hitting their chest on the steering wheel, we have things we need to consider as well as getting a good set of lung sounds, getting pulse oximetry, checking for difficulty breathing, any kind of chest pain, palpating the ribs, because there's a lot of potential here for a tension pneumothorax, also flail chest, fractured ribs, and these patients are going to need pain management to help with this as well. As you can see here, looking at the passenger's internal organs and against solid structures of the body. This guy obviously going headfirst into the windshield, causing a potential for a frontal fracture from the frontal bone to the frontal lobe. And if you notice that the back of his head is a little purple as well, so if you can see my mouse moving on the screen here, we have the frontal and the occipital lobe with the occipital bone back here. Your brain, remember, it sits in fluids, right? So if you hit contact here, the brain goes forward, causing contusions. If they come back into their seat, now the brain comes back and smacks the backside of the occipital bone, causing contusions. This is what they call a coupe contra coupe injury, going back and forth. And this could happen multiple times as you go back like this, right? Which can make it very life-threatening. But if all we see is some abrasions to the front of the head, we may say, oh, it's just an abrasion, keep moving forward. But really, internally, things we can't see is potential for brain swelling. So we got to pay attention to that, looking at different signs and symptoms to be able to pick this kind of stuff up. One of them is what they call Cushing's triad. Cushing's triad is bradycardia, irregular respirations, and then the hypertension. So you got to look for that as well. Significant MOIs. Someone said something. Sorry, I cut somebody off.
Sorry, I accidentally hit the mic on button.
No worries. I'll make sure I didn't miss something. So vehicle crashes as well. Significant MOIs include the following findings. So if you have a death of an occupant in the same vehicle, that patient that's still alive is considered significant, considered critical. Because if it was strong enough to kill the person next to them, they may have some injuries as well. They need to be transported right away. Severe deformity of a vehicle or intrusion into the vehicle itself. So when the vehicle strikes an object, with newer cars, the fronts of these vehicles are designed to have crumple zones. So they come in significantly. That's why I said when you show up, you're like, holy crap, that's a bad crash. And yet they're out walking around on their cell phone because they're designed to crumple. But when you hit so hard to the point where the patient compartment starts having intrusion, okay, that's what I'm looking for. That's what I'm going to look for the potential for more injuries. Because that vehicle that's designed to crumpled so much it actually did damage to the patient compartment. Severe damage from the rear of the vehicle. Okay, if you have severe damage or rear end collisions, I got to think about the coupe contra coupe brain injuries. Crashes when there's rotations involved, if it's hit and they're spun in or rolled over, I need to consider more internal injuries of these organs. Remember, organs aren't designed to be flipped and tossed and turned. So something's going on creating more force. Or ejection from the vehicle not wearing a seatbelt and how far they got ejected as well. And when you get there and you see this and you see the patient, all right, or if they're entrapped in the vehicle and they're utilizing extrication tools to remove the wreck from the patient to get the patient out, things you might want to think about as well is maybe air medical transport to a trauma center. So know your area, where you work, what you have for resources. If you're up in this Ospey Valley, our closest trauma center is Portsmouth, okay, which is an hour away. So what does this patient need during that 1 hour transport? Or if it's going to be a half an hour extrication plus an hour transport to the closest trauma center, one of the things I'm going to think about is aeromedical transport if they're critical, because now it's in it, it takes a half an hour, it's an hour and a half of waiting. We really want to hit that golden hour and that platinum 10 minutes and then the golden hour to get this patient to definitive care. So things to think about in motor vehicle accidents if you need aeromedical transport. Evaluate supplemental restraint systems. Determine whether the passenger was restrained or whether the airbags were deployed. Now, if you have a frontal impact, let's just say frontal crash, and the airbags did not deploy, that can also be a problem and a danger for the patient and for the providers going into the vehicle. So keep that stuff in mind. And make sure you get the proper drain times and everything else. And sometimes you don't have time for that. So if you don't, protect yourself. Seatbelts and airbags are effective in preventing a second collision inside the motor vehicle. But things to think about with that, though, okay, is remember seatbelts also have pretensioners. So if they're in a motor vehicle accident, what's supposed to happen is that seatbelt's supposed to pull back and hold you to the seats so you don't go into the steering wheel. But remember, that's also fired off when it does that. So you got to be careful with the seatbelts as well. So cut the seatbelts off if needed to get these patients out. Airbags decrease the severity of the deceleration injuries and decrease injuries to the chest, face, and head. But it comes out so fast that you may actually have some injuries to the face if their face goes into the airbag. And they're also very hot. In one of my extrication classes, I like to, if I have an airbag available, I like to deploy it and then cut it open. And literally, if you bring eggs with you, you can fry an egg on the detonator of an airbag once it's been deployed. That's how hot it gets. So kind of keep that stuff in mind when you see that, as they're also being deployed in vehicles. Despite airbags, you need to suspect injuries to the extremities resulting from a second collision or internal organs resulting from the third collision as well. Children shorter than 4'9" should ride in the rear seats. In a pickup truck or a single-seated vehicle, the airbag should be turned off in those if they have the ability to do that. Remember that if the airbag did not inflate during the accident, it may deploy during an extrication, which is why we needed to remove the battery or disconnect the battery. Disconnect the battery. All right, so taking your tools out and actually disconnecting it. Please do not cut cables. All right, disconnect them the appropriate way, and then drain the energy out of the vehicle itself. So when you're looking at this picture here, what do you guys see for potential injuries? Tell me what you see. And what do you think could be wrong with this patient?
Is his stomach extended?
Maybe a little bit. What else do you see?
Internal.
Somebody said something and I missed that, sorry. So don't worry about this discoloration up here, okay? That's all betadine and everything else because they put a central line access here. What about this red mark? What would that be from?
Seatbelt.
Seatbelt. So, again, potential for chest injury in here. Now, what about here? Any discoloration through this area here? Or upper quadrant, lower part of the thorax? Potential for internal injuries here. Potential for rib fractures over here. What they're not showing is the pelvis. So you can pick up, just by looking at this patient, you can pick up a lot of different things in here. Remember that supplemental restraint systems can cause harm. Whether they're used properly or improperly, you can see that there's damage here, right? It looks like there's a lot of discoloration on the shoulder up here, all right? So up on the left shoulder. It potentially could be a clavicle fracture that may be here, or a shoulder fracture itself. So again, pick up on the different signs that are there and then start treating. I see Kelsey put down spinal injury as well. So yeah, absolutely. If you have enough impact to cause this to happen, you are going pretty fast, especially to cause that kind of the bruising up in the shoulder area, potential for that kind of fracture. So any patient like this, obviously do not rule out C-spine for these patients, especially if they have a significant MOI. We still want to, we don't need to backboard them, but we need to make sure, obviously, unless we need to do rapid extrication, but we're going to put on cervical collars on all our trauma patients. Don't rule it out. You're just opening yourself up to more liability if they do actually find a fracture, right? So C-collar people. Look for the contact points between the patient and the vehicle as you perform a simple, quick evaluation of the interior of the vehicle itself. Before you transport a patient, either your driver can get out, or your partner can get out and take a look at the vehicle. There's nothing wrong with taking pictures of the vehicle. Actually, it's very helpful, especially around here. The physicians love it when you take pictures of these vehicles and bring them there so they can actually see what you are seeing. Right, and that helps make a lot of determination. So if you have your phone, you can take shots of the vehicles and then bring them to the hospital. Please do not post them on social media. That's what gets you into trouble. But if it's used for medical care, absolutely. And another cool thing about taking pictures on your phone is you can upload those to your run reports. So you can actually put that kind of documentation underneath your attachments. So utilize the stuff that you have and the tools that are there. Rear end collisions known to cause whiplash injuries or the coupe contra coupe injury. Particularly in the absence of headrests, so as you can see here. So as the body is propelled forward, the head and the neck are still left behind. An acceleration type injury to the brain is possible. And that's, again, the coupe contra coupe injury. So the third collision of the brain within the skull. So back and forth. Those are your body organs moving. Lateral crashes or side impacts, or T-bone. Very common cause of death associated with motor vehicle accidents, because remember, there's not a ton of protection on the side versus front and rear. Now, I know they're making curtain airbags to protect. Remember, those things come down about 12 to 14 inches or so, and they come out at about 200 to 300 miles an hour straight down. They come down fast to protect that side impact. However, you still have, there's not much metal in here. Now, you have bars that run through here that have a lot of tensile strength that run through these doors to help protect you from those side impacts. But even still, enough force behind it can actually bend some of these bars and cause significant intrusion to the vehicle. So if you are not seatbelted, expect to where the patient could be. So again, if you find a patient buried down in the wheel well, in the inside the vehicle, passenger underneath the dashboard, could they have been the driver that hit, and when the vehicle came to rest, they went back across the seat and down underneath? Don't think that there may have been a second patient. There could only be one. So again, ask, is there anybody else in the vehicle with you? A vehicle struck from the side is usually struck above its center of gravity. It begins to rock away from the side of impact and results in the passenger sustaining a lateral whiplash type injury. Also consider your aortic dissections as well, and significant injury inside the body, so in the abdomen, and also spinal, because remember, we're shifting everything where it shouldn't be. Substantial intrusion to the passenger compartment. Suspect lateral chest and abdomen injuries on the side of the impact. So think about kidney injuries, spleen, things like that. Possible fractures to the lower extremities, pelvic, and ribs. So remember, low impact, hard hit, impact on the side, and it can cause your pelvis to shift, causing significant injury as well there. Organ damage from the third collision as well. Large trucks and sporty vehicles are also prone to rollovers. So you got to keep that rollover crash stuff in mind, and how many times it did roll, where did it roll, and how it ended up. Injuries depend whether the passenger was restrained or not. And there are some pretty interesting videos that are out there showing rollovers and where people go inside the vehicle. Most common life-threatening event is ejection or partial ejection of a passenger from the vehicle. So if you go to a motor vehicle accident rollover and you heard that there's multiple people, don't just look around the vehicle, look underneath the vehicle, and look up in trees. I've been to a select few motor vehicle accident rollovers where we've had patients that have actually been up in tree branches. They've been thrown out of vehicles. It doesn't happen very often, but I've seen it a couple times in my career. So look up, down, and all around underneath the vehicle if you can. Remember, I'm teaching you EMS stuff today, so we're not the fire department. So if the vehicle is not stabilized, we don't go in until the vehicle is stabilized and you're trained to do so. Rotational crashes are spins that are conceptually similar to rollovers, but the rotation of the vehicle provides opportunities for the vehicle to strike other objects such as utility poles and things like that. So again, just keep an eye out when you're getting on scene. Look at tire marks and things like that as well when you get there on the pavement or even on the dirt, and see if there was a rotational type crash that caused this. Car versus pedestrian, obviously injuries are more often graphic than apparent. So again, you can also be serious. There can also be serious unseen injuries as well. So we have to figure out how fast the vehicle was going. So you need to find out how fast were you traveling before the pedestrian was struck, whether the patient was thrown through the air. So again, look at bystanders, witnesses, things like that may have seen the patient get thrown. Whether the patient was struck and pulled under the vehicle. You know, were they riding a bicycle and they got hit and thrown? Were they walking and they went underneath the vehicle and got run over and dragged? So again, look at everything, your surroundings, talk to people, find out what exactly happened. That's going to help determine your injury patterns. Evaluate the vehicle that struck the patient for any kind of structural damage. ALS backup should be summoned for any patient who has sustained a significant MOI. At the EMT level, obviously, we can't do IV therapy, fluid therapy, cardiac monitoring. Well, you can now in Maine when it's coming to the 12-lead stuff. But you want to get this kind of stuff on these patients and get fluids and IV therapy and potential for pain meds. And so get that ALS coming, all right, and get them on board. Car versus bicycle. You want to evaluate like you would for a car versus pedestrian collision. So look at the damage to the position of the bicycle itself, and if the patient was wearing a helmet, inspect it for damage. Don't just inspect it. Bring it with you. Bring it to the hospital and show the doctor. All right. Let him know this is the helmet from the vehicle. This is what I'm seeing. So they can actually see those kind of injury patterns. Again, helmets do save lives, but I've seen helmets and I have pictures of some that I can show you guys in the next class, Sunday class that I'm there for, of a ski injury that I had with a 9-year-old. And he actually had a significant head trauma to the point where we ended up intubating him before he went into the helicopter. And he was skiing and had a helmet on. The helmet protected him, but it still caused a significant fracture to the frontal bone of the head. So they do help protect, but still, these patients here need to be assessed for head trauma as well as the rest of the trauma throughout the body. So presume that the patient has sustained an injury to the spinal column or spinal cord until proven otherwise at the hospital. Do not rule that out. So again, cervical collar. If they're on the ground, we can use a scoop stretcher to pick them up, put them onto the stretcher. We don't want them standing. When they're on the stretcher, we take the scoop off and we secure them to the stretcher. Spinal stabilization must be initiated and maintained during the encounter. So again, holding C-spine, placing the cervical collar, and protecting that cervical spine, and then keeping the patient straight without doing any kind of bends or movements to prevent any other kind of spinal cord injury. Car versus motorcycle, obviously protection is from the helmet, leather, or abrasion-resistant clothing, and the boots. Not everybody wears all this kind of stuff in the summer, in the hot summer months. So collisions usually occur against larger vehicles or stationary objects. So you just got to kind of keep in mind when you get to the scenes of motorcycle accidents and where they went. Motorcycles into the woods. Remember, it's like a ping pong ball bouncing off different trees. These patients are like ping pong balls bouncing off trees. So think of different injury patterns as well from that. When assessing for the scene, look for a deformity of the motorcycle. Again, take pictures of it if you have it, so that way there the physicians can see it. Look for the side of the most damage. So where was it struck from? If they skid in the road, what was the distance of the skid? Deformity of the stationary objects or other vehicles that were there, and extent and location of the deformity in the helmet. Take the helmet with you to the hospital so that the physicians can see that. Head-on crashes, motorcycle strikes, and other objects and stops in its forward motion while the rider continues moving forward. So you may have a head-on crash and the rider goes up over the handlebars and either into the vehicle or up over the vehicle and on the other side, or an angular crash where a motorcycle strikes an object at an angle, so the rider sustains direct crushing injuries to the lower extremities. Look for any kind of serious bleeding with these types of crashes as well. And your tourniquets should be readily available in your first in bags, not tucked away someplace in a pocket where you can't reach it. Obviously, ejection from the rider itself, especially the rider will travel at high rates of speeds until they're stopped by a stationary object. Remember, it's still in motion until something stops it, right? So if the bike hits a vehicle while it's in motion, it stops that motion, but your body keeps going until that is stopped by another force. That could be the ground, a tree, another vehicle. Also, we also have controlled crashes, where techniques used to separate the rider from the body of the motorcycle itself. So they know they're going to be going down, so it's a controlled crash. Severe abrasions can definitely occur. It is not our job to pull the rocks and gravel out of someone's wounds. Okay, we can give them pain medicine if we need to wrapping the wounds very lightly to protect it from any more infection. But again, it's not our job to start pulling rocks and things out of their skin. They're probably going to want pain management for that. And these patients, usually that are really bad, end up getting conscious sedation, so they can actually take the metal wire brushes and actually go through the skin itself to kind of pull out all the infection and the rocks and gravel and dirt. These patients are really treated pretty heavily with pain meds, especially in the ER for this. All right, so falls. So injury potential depends on the height of the fall. So more than a 20-foot fall is considered significant. Usually it's 2 times the height of the patient itself. Internal injuries pose the greatest threat to life with these, because remember, if they fall and they don't see any injury, it doesn't mean that something isn't going on internally. So we need to make sure that we are palpating these patients from head to toe. We got to find what's wrong with them, right? Especially abdominal pain as well. So as you can see, calcaneus fracture, or the calcaneus here, this is a patient who fell and landed on their feet. Which may have less severe internal injuries, but their legs may have absorbed much of the energy of the fall. But again, you may have someone that falls straight down. As they're landing on their calcaneus or their heel, that energy is then driven up into the pelvis. And this here can actually cause pelvic fractures and or potential for a femur or a midshaft, but more of a femoral head fracture, because you have that energy pushing against that. So think of the femoral head. Where's my mouse? So the femur coming up like this, and then it kind of curls in like that into a ball and socket going into here, right? A lot of times you'll have a fracture right at the proximal end of the femur, causing that fracture. So take the following factors into account: the height of the fall, the type of surface that was struck, whether it be concrete or grass, depending on it, and the part of the body that hit first, followed by the path of energy displacement. So again, feet first fall, landing on their feet, the energy has to go somewhere, so it displaces itself up through the tib fib, into the knee, into the femur, up into the pelvis. All right, so penetrating trauma is the second leading cause of trauma death after blunt trauma, whether it be accidentally being impaled or intentionally by a knife, ice pick, or any other weapon, as you can see here. If we have an impalement like this, or penetrating trauma, if the object is still there, leave it there. Okay, do not remove these objects unless, we'll get into that, the unless part here in a moment. So like this guy here with a penetrating trauma, we're going to stabilize that in place in transport. If you have a guy that fell through and landed through rebar, we might have to cut above and below it to transport this patient. All right, and that's a different class, different lecture in itself on how we're going to make those cuts. This is more just for our treatment here. and how to displace energy and how to displace heat when doing these types of cuts. With low energy penetrations, injuries are caused by the sharp edges of the object moving through the body itself. Like knives, they may have been deliberately moved around internally, causing more damage than the external wound actually looks like. So if they go in and they make that penetrating trauma through the integumentary system or the skin into the organs, when it's in, they can be moving up and down and around, causing more internal injury. So again, if it's still in place, leave it in place. If it's removed out, we need to pack it and get it to stop bleeding by applying different dressings. So the path of the projectile may not be easily to predict as well. So the bullet may ricochet. So if you get a penetrating trauma from a bullet, it may ricochet within the body before exiting. So it might not be a straight through and through. If it hits a bone, it's going to ricochet and go to a different location. So you have to keep that kind of stuff in mind. The path of the projectile usually takes in its trajectory. However, fragmentation will also increase the damage as well, and the bullet's speed is also another factor. So I am not a gun guy by any means. So those of you who are gun guys that are in the class, I mean, obviously the bigger the bullet, the bigger the hole. You got to look for this kind of stuff, okay, as they go through. Is it more of like a bird shot type where they have multiple penetrating traumas, or is it a single bullet that goes through? Again, we have to figure that kind of stuff out. We have to know about the guns that are the bullets and the type of bullet that is entering the body, and in hopes we find that exit point. When there is no exit point, that's when it becomes a problem because we have no idea where that bullet may have lodged. All right, so it's always good to have an exit. So cavitation results from rapid changes in tissue and fluid pressure that occur within the passage of the projectile, as we can see here. Bullet comes through the skin, right? Creates this is the temporary cavities here, causing inflammation and movement. We have permanent cavity here, as the bullet comes out. Hopefully, in turn, will exit. This can result to a serious injury or to internal organs as it penetrates through. So again, we just need to understand our layout, our pathophysiology, and our anatomy and physiology of how the body systems actually work and where things are located to have a rough idea of where or what types of internal injuries could potentially be here. Now, obviously, shot in the abdomen or chest, there's not much we can do internally to fix that, but we can definitely help with sucking chest wounds or abdominal trauma during this. So the relationship between the distance and severity of the injury varies depending on the type of weapon involved, whether it be air resistant or a drag that slows the projectile. The area damaged by projectiles is typically larger than the diameter of the projectile itself. We also got to consider energy being available for a bullet to cause the damage is more of a function of its speed than its actual mass. So again, look at what penetrated the body, depending on what penetrated the body, and how the projection of projectile and project where it may potentially have gone. So recognizing and developing problems in the trauma patients. I'm going to leave this slide up here for you guys to read through because it is very small on my screen. I can barely see it. All right. And again, this is being recorded, so you guys can go back to the slide, and it's also in your books as well, in your ebooks. All right, so a little bit about blast injuries. So the most common in military conflict, also seen in mines, shipyards, chemical plants, and terrorist attacks. With blast injuries, we have our primary blast injury, where injuries are due to the blast wave itself. Right, so explosion, blast wave comes off, causing your primary blast injury. Then you have what they call a secondary blast injury, which are injuries due to the missiles being projected or propelled by that blast force. So now remember, we have the wave coming out, we have projectiles coming at us, and we have the tertiary blast injury, which injury is due to the impact with another object. So now we have, remember, the blast first. We have the objects coming at us. We're falling over. We're being penetrated by these projectile missiles coming at us. We're hitting the ground for the tertiary blast injury. We have the quaternary blast injury, which is collateral injuries such as burns, crush injuries, and toxic inhalation. So with a blast injury, remember, we have 4 different types of things we got to think about. Remember, the waves coming off, knocking the body over, projectiles entering the body, us hitting the ground, causing into another object, causing more injury than anything else with like burns, injuries, toxic inhalation, depending on what exploded, getting into our lungs, causing even more damage or other burns to our skin. So blast injuries are actually very dangerous. So primary blast injury due entirely to the blast itself, damage by pressure waves coming at you. Then we have the secondary blast injury, damage to the body results from being struck by flying debris. The tertiary blast injuries, where the victim is hurled by the force of the explosion, hitting another object. And the quaternary miscellaneous blast injuries, where burns from hot gases or fires started by the blast. Respiratory injury from inhaling toxic gases, and crush injury from the collapse of a building or something else that came down on top of you. So most patients will have some combination of these 4 types that we come in contact with. Remember that if we have crush injuries, we have to be very careful on how fast we lift these things off patients. Because remember that patients that are being crushed build up a lot of lactic acid and buildup, causing a patient to become very acidotic. With that being said, there's specific medications, and as far as the crush injury part goes, they have to be administered before all those toxins get released into the body, causing the patient to become very hypotensive and die. All right, so these calls require ALS paramedic care to get the IV and the fluids and the potential for giving either albuterol, calcium gluconate, sodium bicarb, other medications that medics will use to help push potassium out of these cells to help prevent any kind of further lactic acid buildup in the body going through the system. Organs that contain air are the most susceptible to pressure changes, like the middle ear, the lung, and gastrointestinal tracts. The ear is the most sensitive to a blast injury, so you may have ear issues as well. We want to make sure we're getting good sets of lung sounds and actually palpating the intestinal tract, the abdomen, all 4 quadrants, to see if there's any kind of injury that's there. So remember, organs that contain air, so your hollow organs. The pulmonary blast injury result from short-range exposure to the detonation of explosives itself. So with that, you can have arterial air emboluses that can actually be produced. So disturbance in vision, changes in behavior or state of consciousness, and a variety of other neurological signs that you might find. So we need to make sure we do an in-depth neuro assessment on these patients, checking pupils, asking if they have any blurry vision, to doing stroke assessments for neurologic stuff, see if they have different feelings, whether it be like, can you feel one side of the face and the other side of the face is different? Changes in behavior or state of consciousness, are they altered? Asking them the appropriate questions, person, place, time, and events. Solid organs are relatively protected from the shockwave injury. Again, may be injured in secondary missiles or a hurled body, but the actual blast itself with solid organs usually don't have that. And traumatic amputations are also common as well. Now, your multi-system trauma involves, remember, more than one body system itself. So a lot of people get this confused, multi-system trauma. I mentioned that earlier. But if you have head and spinal, chest and abdomen, chest and multiple extremity trauma, again, multiple body systems are being injured, whether it be respiratory, cardiovascular, integumentary, musculoskeletal, right, renal system. If you have multi-system trauma, we want to alert medical control. So we want to call the hospital and know you're coming in with a trauma alert. If you're at the medic level, when you call for ALS, they may divert you to a level 1 trauma center or level 2 trauma center that can handle this. So the golden principles of prehospital trauma care would be your main priority is to ensure your safety first, the safety of your crew, then the safety of the patient. We're going to determine the need for additional personnel or equipment and evaluate the mechanism of injury that's we're seeing in front of us. Then we're going to identify and manage life threats. Again, if we have arterial bleeding, tourniquet, move forward. Any kind of other life threat, being like pelvic fractures, things like that, we need to stabilize. Life threats, manage them. ABCs, airway, breathing, circulation. Shock therapy. They're not talking about shocking patients. So shock therapy, getting the patient warm, monitoring vital signs, spinal mobilization, placing a cervical collar, and transport to the most appropriate facility. Definitive care requires surgical intervention. So where they have an OR, on-scene time for these patients should be limited to 10 minutes or less if possible. This is your Platinum 10. Then obtain a sample history and complete a secondary assessment. If the trauma centers are far away, consider ALS intercept or air medical transportation. Remember that the helicopters also bring blood products, so if the patient has internal bleeding or bleeding out, ALS paramedics, AEMTs, they can give fluids like normal saline. The problem with that is it just turns blood into Kool-Aid. What they really need is whole blood administered. So helicopters, the services do carry the blood products to be able to administer in the field. Something to think about, that's all. So when doing our patient assessment, when there is a patient that has experienced a significant MOI or is in critical condition, rapidly perform your physical examination. That's your rapid trauma assessment, head to toe, 90 seconds. When a patient has experienced a non-significant MOI, we can focus on the chief complaint. So if they fell and they hurt their knee, we can do a quick rapid, then we can do a focus assessment on just his knee. We don't have to go in detail if it's a significant, unless it's a significant type of incident. Injuries to the head, remember disability and unseen injuries to the brain may occur, right? So we want to look for the Cushing's triad. Bleeding or swelling inside the skull is often life-threatening. So we got to look for those changes in blood pressures, changes in respiratory patterns, changes in heart rates. Include your frequent neurological examinations in your assessment. Remember doing your stroke scale, grips on each side. Are they equal? What finger am I touching? Is it sharp or dull on either side? Remember your CSM, circulation, motor function, sensitivity, sensory. Some patients will not have obvious signs or symptoms, so you need to ask them questions if they're alert and oriented. Now, we also want to monitor that as we're doing our assessments, because if the patient is alert and oriented, and we start asking them, hey, what's the month, day, and year and president again, or person, place, time, and event, and they don't know, now we're starting to see a trend of potential for more brain trauma, causing maybe our potential for traumatic brain injury, TBI, because now the patient is becoming more altered. Some areas of serious injuries to the neck and throat are areas of serious or deadly injuries. Remember, we need to have our neck. Remember, our cervical spine is there. Remember, C3, 4, and 5 keep the body alive. Anything with that, it can kill you off. All right. So airway problems may also result with this. Look for decap BTLS in the neck region. So it's deformities, contusions, abrasions, punctures, and penetrations, burns, tenderness, lacerations, and swelling. Decap BTLS. And swelling may prevent blood flow to the brain itself as well if you have significant swelling in the neck, by pushing pressure on the carotid arteries that supply the brain with the oxygen-rich blood that the brain needs. Penetrating injuries may result in air embolisms as well. If there's a penetrating injury to like the face or whatever, the airway, we may have to stabilize that unless we can't gain access, and sometimes we may have to remove certain things to make sure we have an airway that's open. Crush injuries may also cause the cartilages of the upper airway and the larynx to fracture also. So keep that kind of stuff in mind when doing our assessment. That's why we feel the trachea during our rapid trauma assessment. For one, tracheal deviation, one side to the other. Remember the tracheal deviation, the trachea moves to the lung that's actually working more. That's a late sign of tension pneumothorax. We also want to see if there's any kind of crepitus or crunchy type feeling under the skin as well. Injuries to the chest, the determinant of the chest contains the heart, lungs, and large blood vessels. So many life-threatening injuries may occur here, especially broken ribs that may hinder the breathing. The heart may be bruised, like a pericardial tamponade. So pericardial tamponade, you'll find with something called Beck's triad. So there's 3 things with Beck's triad that an EMT can find. One would be hypertension. Nope, take that back. Not hypertension. Sorry, I was thinking of Cushing's. Beck's triad is muffled heart sounds. So if you listen to the heart, it sounds very muffled. A jugular vein distension. So your veins will actually be distended in the neck. So neck veins distended. All right. And the third one is narrowing pulse pressures. So if you take a blood pressure and it's like 90/86, they're very close blood pressure. Those are the 3 indicators that your heart's not pumping that could cause a contusion or a pericardial tamponade from the type of injury. What they need for treatment, nothing that even a paramedic can do. This is something that has to be done in the hospital, is what they call a pericardial centesis. And to do that, they have to stick this really long needle into the heart and pull that fluid out. So injuries to the chest can cause a lot of significant damage. A penetration or perforation of the integrity of the chest also called an open chest wound. If untreated, shock or death will result. Assess the chest region every 5 minutes, and assessment should also include decap BTLS, lung sounds, chest rise and fall. Make sure that's equal. We don't have equal bilateral chest rise and fall. If they're not rising the same, then we have an issue. Potential for a collapsed lung. Palpate, have the patient take a deep breath in and out. As we're doing that, remember, encompass the chest wall with both your hands. So if in a female, under the breast, wrap around the chest itself and feel for chest rise and fall that's equal. You don't feel any crepitus or flail segment. And flail segment, remember, is 2 or more ribs broken continuously. All right, that'll be the flail segment that you'll find. Injuries to the abdomen. Abdomen contains vital organs that require a very high amount of blood. If you have an injury to an internal organ, you can bleed out very quickly. Solid organs include the liver, the spleen, the pancreas, and the kidneys, and your hollow organs include the stomach, large and small intestines, and the urinary bladder. If we have a liver, spleen, pancreas injury, or kidney injuries, and we're bleeding out, expect to see the abdomen very distended and very hard to the touch, okay? And very tender, very painful. That means that we have a lot of free fluid or blood that's free in the abdomen that is not where it's supposed to be. So a lot of times when you go to an ER or trauma center, they're going to take an ultrasound out and do something what they call a fast scan, F-A-S-T, so fast scan. They go right over the top of the abdomen, and all they're looking for is free fluid. They see it, right to the OR. Patient needs to have surgery right away. Solid organs may tear, lacerate, or fracture. Hollow organs can rupture or leak toxic digestive chemicals into the system. Either way, both not good for the abdomen, right? One can cause infection, one can cause a patient to bleed out. The rupture of the large blood vessel can also cause serious unseen bleeding, like the aortic aortic dissection. The aorta actually dissecting, causing yourself to bleed out. So as we're palpating the abdomen to look for any kind of potential for aortic issue, we want to feel for pulsating masses. So if we're pushing down around the umbilical and they have significant pain and you palpate and it's pulsating, right, there potentially could be a aortic type injury. So you got to keep that stuff in mind as well. So management of death, transport, and destination. So scene time is important. Remember, 10 minutes on scene or less to get these significant patients out into a trauma center. Critically injured patient, dangerous mechanism of injury, decreased level of consciousness, or threats to an airway, breathing, or circulation. The type of transport, the ground EMS units are staffed by EMTs and paramedics. Air EMS are staffed by critical care transport units are staffed by critical care nurses and medics as well. So they have more of a higher ability to treat these patients in the air, where they can actually place chest tubes in the field and things like that versus just doing decompressions that medics are doing. So they have different abilities in the air to be able to do stuff. Excuse me. AMS and Medevac Foundation and International identify criteria for emergency or medical services for trauma patients. So this is where we start getting into our level 1, level 2 centers. So extended periods require to access and extricate a remote or trapped patient. Patient needs ALS care and no ALS level ground transport services available. We have multiple trauma patients and mass casualty incidents. So let's get into that here. We need to figure out where these patients are going to go. So as far as your mass casualty stuff goes, that's going to be a different lecture towards the end of our program. So I'm not going to go in depth on MCI stuff yet. But we need to figure out where these patients are going to go. Level 1 facilities serves large cities or heavily populated areas, provides every aspect of trauma care and usually university-based hospitals. Level 1 centers around us. There's only one level 1 trauma facility in New Hampshire, and that is Dartmouth-Hitchcock in Lebanon. Then we have Maine Medical Center in Portland. Then we have level 1 trauma centers in Boston. And then Leahy Burlington is also in Mass, is also a level 1 trauma facility now. The biggest thing between level 1 and level 2 usually is one, it's a university-based type hospital, or they have a teaching affiliation. But the second part is 24-hour neurosurgery and neurology there, versus your level 2 centers that do not have 24-hour neuro, but they are on call. Portsmouth Hospital really should be a level 1 facility. It just doesn't have the teaching facility for med students. But they do have 24-hour neuro now. The level 3 facilities provide assessment, resuscitation, emergency care, and stabilization. And they transfer patients to level 1 or level 2 facilities when necessary. The level 4 facilities are found in remote outlying areas and provide advanced trauma life support. So they consider Memorial Hospital and Huggins Hospital for us in this area critical access, where you have access to critical management via transfer to another hospital, but they can still treat you at that facility before they transfer you out. So trauma centers are categorized as either adult trauma centers or pediatric trauma centers. They're not both the same unless they specialize in both. Do not transport a pediatric patient to an adult trauma center when a pediatric trauma center is available. Now, for us up here, we're going to go to Portsmouth, and they're going to be able to transfer from there. Maine Medical Center is adult and pediatric trauma. Dartmouth has adult and pediatric trauma. So again, flight may be the better option for these kids. And I can't read any of that at all. So you guys will have that on your screen to take a look at. That is just way too small. Now, in your protocol books, or if you download the protocol books on your phones for the states that you're working in, I would recommend getting the Paramedic Protocol Provider app. Even though it says paramedic, that's fine. It's like a $10 app, but it has all the different states in the U.S. Their protocols are in there. That's what I utilize for the 3 states that I hold licenses in, so I can switch back and forth. It makes things a lot easier. So special considerations would be remain calm, complete and organized assessment, correct any life-threatening injuries, do no harm, and never hesitate to contact ALS backup or medical control for guidance. There's nothing wrong with calling the doc and having a consultation with them. All right, so let's do some review really quick, and we'll get into bleeding. I do apologize. This is probably one of the longest nights that we've had. I just don't want to fall any more behind than what we are. So kinetic energy is a calculation of what?
B.
I'm seeing C's. I think I heard B as well.
B.
All right. So the correct answer is B. Kinetic energy is a calculation of mass, weight, and velocity speed. So remember, it's half the weight times velocity squared. Energy cannot be destroyed, but only converted. So a 20-year-old man has a major open facial injury after his vehicle struck a tree head-on. Which of the following findings within the car would most likely explain his injury pattern? Facial injuries. after striking a tree head-on, so frontal collision?
D.
We're looking at facial injuries.
C.
Seeing C.
Oh,
So if you're not, so the answer would be C. The mechanism of injury and conditions of the vehicle interior suggest likely areas of injury would be head and neck injuries are likely when the head and the face impact the windshield. So if they're not belted and you see a lot of facial trauma, did they come up and hit the windshield? So if you see a non-displaced windshield, then most likely going to be their facial fracture. So let's just say non-intact. Which of the following would most likely result from the third collision in the tree collision? In the three collision. Effect that occurs during a high-speed frontal impact motor vehicle crash.
D.
B.
So the answer is D. So remember what I mentioned before? We have three types of collisions that happen. Three collisions happen in a motor vehicle accident. So the vehicle strikes an object, that's collision number one. Our body strikes the inside of the vehicle, collision number two. Our organs in the body strike our integumentary system, that's collision number three. So look at aortic tears resulting in massive internal bleeding because that's the third impact inside. Number four, so a young male experienced severe blunt chest trauma when his passenger car struck another vehicle head-on. During your inspection of the interior of this vehicle, you would most likely find what? Chest trauma. So think of what your chest would be striking. All right. Lots of B's going up on chat. Perfect. B it is.
I was gonna say I was stuck between A and B.
Versus deployed airbags. So we're hoping that
Right.
we don't see the chest trauma on a deployed airbag that's supposed to absorb that impact. But yeah, it could be tossed between both. So National Registry type questions. Which one's more right than the other? That's how they're gonna trick you up. Not a huge fan of how they trick people up in questioning. So an unrestrained driver collided with a bridge pillar. Upon inspection of the interior of his vehicle, you note that the lower dashboard is crushed. During your assessment of the patient, you would most likely encounter lower dashboard. So think of what part of your body would be more lower.
A.
Perfect. See a lot of A's. Whiplash injuries are most common in what type of impact?
A.
A's. A it is. Number 7. Death from a rollover motor vehicle crash is most often secondary to
C.
So I'm seeing C's and I'm seeing D's.
Which one's more right?
Exactly. Rollover, ejection. This one's more right than the other. Severe abrasion injuries can occur when motorcycle riders are slowed after a collision by road drag. Road drag is most often associated with which type of motorcycle impact?
C.
See what's popping up here. C it is. Ejection. Number 9. So when assessing a stab wound, it is important for the EMT to remember what? Remember that. All right. So the answer is D. I saw a lot of D's come up on there. And number 10, a 40-year-old man was standing near a building when it exploded. He has multiple injuries, including a depressed skull fracture, severe burns, and an impaled object in his abdomen. His head injury was most likely caused by which blast injury? All right. Seeing some C's pop up. All right, tertiary injury. Perfect. All right. Let's just take a couple minutes while I bring up the other presentation here, and we'll finish up the bleeding and then call it a night. All right, we'll get started on bleeding. All right, so bleeding, recognition and management of bleeding itself, pathophysiology and assessment and management of bleeding. And we're going to apply the fundamental knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. So important to be able to recognize bleeding. Yes, obviously we need to look for bleeding anywhere it may come from. Understand how bleeding affects the body. As well, bleeding can also be external or internal or external, and bleeding can cause weakness, shock, and death. So we're going to go through all this stuff here. So the cardiovascular system circulates blood to the cells and tissues, right? So we talked about that before. Inspiration, expiration, air goes in, round and round inside the blood. Oxygen is transported through the blood system to the capillary beds, transitions that out with carbon dioxide, and that is expelled through expiration. It also helps cure away metabolic waste products. It's also responsible for supplying and maintaining adequate blood flow. So we have to have a good cardiovascular system in place. So remember, we have three different parts. We have the pump, which is the heart, the container, the blood vessels, and the fluid, which is the blood and bodily fluids within inside. All right, I think we've hit this a lot already on how blood pumps through the body, whether it be oxygenated versus deoxygenated, and how we go around and around inside. So with the heart, remember that it needs a rich and well-distributed blood supply. And remember, this works as two paired pumps, the upper chambers, which are the atriums, and the lower chamber, which are the ventricles. We have right and left. Blood leaves each chamber through a one-way valve. And the valves would be the tricuspid valve, pulmonic valve, mitral valve, aortic valve. Those are the four valves of the heart. And remember that we have the four chambers, right and left atria, right and left ventricle. Remember that the right side of the heart has the, deoxygenated blood, pumps down through, back in through into the lungs, where it's then exchanged, and then back through the left atria to the left ventricle, pumping out into the body. So we have arteries, arterioles, and capillaries. Arteries carry blood away from the heart. This is your oxygenated blood as it goes through the arteries, and then it goes into the arterioles, which are smaller vessels that connect from arteries to capillaries. Then our capillaries pass along all the cells of the body and link arterioles and venules together. So oxygen comes in, transported, goes through the arteries, arterioles to the capillary bed. Waste products come out, new oxygen comes in through the venules, which we'll see next, which are very small, thin wall vessels that empty into the veins. And then the vein is carrying the deoxygenated blood back to the heart. Now, the thing about veins is there has to be valves inside veins to help push that blood, deoxygenated blood, back to the heart to go back to the lungs to be expelled for the toxic gases and new stuff to come back in. So it builds up pressure, but it's still a continuous flow. It's just building up the pressure that's there. So oxygen and nutrients pass from the capillaries into the cells, and the waste and carbon dioxide diffuse. Remember, carbon dioxide being a gas, diffuses into the capillaries, as you can see here, running through. So gases here, oxygen being transported through the hemoglobin of the blood in the red blood cells. Gases come in, O2, gases come out through diffusion, CO2, carbon dioxide, and all this stuff changes into the lungs itself. And then that's how we expel the toxic gases that we have, the toxic waste. So red blood cells are responsible for the transportation of oxygen to the cells and carbon dioxide away from the cells into the lungs. So blood contains white blood cells, which are responsible for fighting infection, platelets, which are responsible for forming blood clots, and then plasma. White blood cells are important for us to pick up on because if you have a patient that's immunocompromised, cancer patients and things like that, they're not going to have many white blood cells, if any at all, which means they're not going to be able to fight off infection. So when we're going into residences, make sure we're protected. Kind of like an off-topic thing, which is we're talking about white blood cells. I'm going to let you guys know about it. So blood clot formation depends on the blood stasis, the changes in blood vessel walls, and blood's ability to clot, right? So we have to have those platelets, and we have to have fibrin, and that helps the ability for blood to clot. And blood clotting is actually a good thing when we have an actual bleed, right? What we don't want is plaque buildup causing a clot that way. We want blood to clot, though. When tissues are injured, platelets begin to collect at the site of the injury. And now the red blood cells become sticky and start clumping together. So they become sticky, and as blood cells are going through it, they stick to each other, causing a clot, and with fibrin and everything else, causing it to clot over so the bleeding actually stops. So the autonomic nervous system monitors the body's needs and what's going on. So it helps adjust blood flow. So if you got a patient that has an injury and they're bleeding out, your heart rate's going to go faster because your body says, oh, we need to transport more oxygen, so let's increase our heart rate. By doing so, though, we're losing blood and our blood pressure starts to come down. And that's when the autonomic nervous system says, hey, we got to start increasing this stuff. Which is why sometimes you'll find faster respiratory drive as well, because now your body's trying to compensate to help expel all that toxic gas, carbon dioxide. And also, in turn, bringing back in more oxygen. That's why we see the increased respiratory rates and increased heart rate tachycardia with patients that have significant injury or significant bleeding. So the autonomic redirects blood away from the other organs as well to the heart, brain, lungs, and kidneys in an emergency also. This adapts to maintain homeostasis and perfusion as well. So if we have a patient that has significant bleeding, they'll start shunting blood away from our extremities into the core to keep our body alive. There we go. Perfusion is the circulation of blood with an organ or tissue to meet the cell's needs for oxygen, nutrients, and waste removal. That's where perfusion is happening. So we talked about the picture here again, arteries to the arterioles to the capillary bed. Perfusion is happening here, right? Perfusing the cells at the capillary bed. Bad stuff comes out, venules, veins, back to the body, or back to the heart, into the lungs. So the speed of blood flow needs to be fast enough to maintain circulation. That's our heart rate and our heart pumping. So slow enough to allow cells to exchange oxygen and nutrients for carbon dioxide and waste products to be removed. So if we have a patient that's very tachycardic, they can become hypoxic, and they can also have lower blood pressures. That's a medical conversation we can have in another class. Patients that are like an AFib or things like that, where they can't pump effectively, but since this is bleeding part, if we're bleeding out, our body needs to compensate by going at a faster rate. Some tissues also need a consistent supply of blood, while others can survive with very little. So all organs and organ systems depend on adequate perfusion to function properly. Again, our body needs three things to survive. Remember, fluids, right, being one, sugar being another, and oxygen. If we don't have all three of those, our brain can't function, our body can't stay alive. So death of an organ system can quickly lead to death of a patient, which is why we need to maintain it. We got to pay attention to our assessments, look at our vital signs, and treat our critical patients with vitals every 5 minutes. Emergency care also supports adequate perfusion until the patient arrives at the hospital to get the other stuff that they need. A lot of patients that have significant bleeds actually need blood products. The only thing is blood products cannot be readily available at a hospital versus calling for flight, right? So the heart requires a consistent pump supply of blood. So the brain and spinal cord may last up to 4 to 6 minutes without adequate supply. The lungs can survive only 15 to 20 minutes. Kidneys can survive up to 45 minutes roughly. Skeletal muscles can last up to 2 hours. And these times are based on a normal body temperature. Again, if they're hypothermic, a lot of this stuff actually changes. Now, patients that are bleeding out start losing body heat as well, which is why it's so important in patients that are in shock to warm the body up, keep them warm. That helps the blood circulate. External bleeding, so if you see the word hemorrhage, that means the patient's bleeding. External bleeding is a visible hemorrhage that we can find. It includes nosebleeds and bleeding from open wounds. If we see it, we can stop it. Whether we use tourniquets, we use pressure bandaging, we can help stop that external bleed. So significance of external bleeding would be serious external bleeding, which may be difficult to tell the amount of blood that's actually been lost. Because blood looks different on different surfaces. If you have someone bleeding out on concrete, it's more apt to spread out more versus someone who's bleeding out on pavement, which should be more secured around the area, versus someone who's bleeding out into grass or some kind of dirt or just soaked straight in. The body will not tolerate a blood loss greater than 20% of the blood volume. When we start losing that, that's when we start seeing patients going into shock. But changes in vital signs may also occur with significant blood loss. We talked about increased heart rate, increased respiratory rate, and decreased blood pressure. Because we don't have enough pressure in the blood, so we become hypotensive. And looking at trauma statistics, we want to keep our blood pressures at a systolic blood pressure of 90. That is pre-hospital trauma life support goals, to keep it at 90 roughly, and not higher and definitely not lower. Because the higher we go, the more the body has to pump, and if there's a bleed inside, we're going to pump out more blood, which we don't want to do. We want to maintain that homeostasis, and what they're looking for is a systolic blood pressure around 90. Remember the increased heart respiratory rate, because our body's autonomic nervous system is saying, hey, we got to increase the heart rate to bring oxygen into the system, and we have to increase the respiratory rate to get oxygen into the system as well, so the blood can transport, and also, in turn, off gas, like the waste products like carbon dioxide. So how well people compensate for blood loss is related to how rapidly they actually bleed. An adult can comfortably donate 1 unit or 500 mLs of blood over 15 to 20 minutes. If a similar blood loss occurs in a much shorter time, the person may rapidly develop symptoms of hypovolemic shock. So consider age and pre-existing health conditions as well, right? To kind of get a rough idea, pediatrics and blood supply, okay? Not very much. Literally, it's about 500 mLs or maybe 2 cans of soda. And that's like soda cans. That's going to be their blood supply. Versus an adult where you could put down 6 1-liter bottles in front of you, and that could be the total blood supply of an adult. Right? We kind of keep that stuff in mind. Serious conditions of bleeding, significant MOI, patient who has poor general appearance and is calm. So looking for that grayish color of the patient, cool and clammy, which would be your other signs and symptoms of shock, along with tachycardia and hypotension. Significant blood loss, looking around and seeing that, rapid blood loss as well, and uncontrolled bleeding, which is why it's so important to get tourniquets and get tourniquets on patients quickly. If you have an arterial bleed, these are very important, especially for testing purposes as well. This is pressure causes blood to spurt and makes a bleeding difficult to control. typically brighter red and spurts in time of the pulse. So if you have a spurting blood coming out of your body, it's an arterial bleed. Venous bleeding is a dark red which flows slowly or rapidly depending on the size of the vein that is cut, but it doesn't spurt. It's easier to manage. Pressure, right? We can kind of manage venous bleeding with pressure itself, versus arterial bleeding where we have that spurting, which we need to stop by either applying pressure to the artery itself, tourniquet, and applying quick clot bandages into that part to cause it to start clotting, right? Capillary bleeding, or bleeding from the damaged capillary vessels, as you can see in the finger, with a small laceration, or capillary bleeding from the wound up here in the upper right-hand side as well. It's a dark red, oozes steadily but very slowly. So when we do a puncture for like a glucometer check or glucose check, that's a capillary type bleed. That's also called the capillary glucose. Clotting, bleeding tends to stop rather quickly within about 10 minutes. That's what's supposed to happen. People can have clotting disorders and become what they call hemophiliacs. So you need to ask them, do you have any clotting disorders? They'll know if they have it because they've already been diagnosed with it. So when the skin is broken, blood starts to flow rapidly. Right? The cut end of the vessel begins to narrow, reducing the amount of bleeding. A clot starts forming, and the bleeding will stop if the clot will not stop if the clot does not form. This is where it's important to do your sample history, because if the patient's on blood thinners, Eliquis, Coumadin, warfarin, things like that, they're losing their ability to actually clot. And that's good for them in a medical sense, because if they're an AFib, we want them to be on blood thinners, or they've had a heart attack and a stent's placed, we want them to be on blood thinners. But in turn, if they're bleeding out, we don't want that. That's why we have parents, if they're significant bleeding, we call for ALS, because ALS carries tranexamic acid, which TXA, which helps promote the clotting to actually stop the bleeding, to help with it. So despite the efficiency of the system, it may fail in certain situations for clotting. Movement, diseases, medications, we talked about that, removal of bandages, external environment, body temperature, and severe injuries. So again, if we have significant bleeding, it's not a bad idea to splint that area as well, so that way it keeps everything from movement. Hemophilia is a patient that lacks blood clotting factors, which we talked about. Bleeding may also occur spontaneously as well. So all injuries, no matter how trivial, are potentially serious in patients that are hemophiliacs. Patients should also be transported immediately with this because they can't stop bleeding, right? And they need to have specific medication to assist with that. And it's more like the factor VIII stuff, which is something we're not going to get into during this. Internal bleeding, obviously bleeding in a cavity or space inside the body itself, or internal bleeding, can be very serious because it's not easy to detect immediately, and it can cause hypovolemic shock. So injuries or damaged internal organs commonly result in extensive internal bleeding. We kind of go a little more into that, okay? If we have broken bones, femurs can roughly hold about 750 mLs of blood per femur, right? The pelvic cavity, if you have a fracture there, can hold up to 3 liters of blood. That is half your blood supply, right? So that's a lot of blood loss, which is why it's so important to make sure we stabilize pelvic fractures so we don't sever those significant arteries that are like the femoral arteries. Stomach ulcers can cause internal bleeding as well, which is why we want to make sure they don't have any active ulcers before we give somebody aspirin. Lacerated liver from trauma, ruptured spleen from trauma, pelvic fractures we talked about, and broken bones like the ribs or the femur as well. Look for the mechanism of injury for internal bleeding, like high energy MOIs, which we talked about in the last chapter, blunt trauma, penetrating trauma, or if you have a high index of suspicion for serious unseen injuries based on the trauma that's actually there. So if you think about it, if you think there might be significant bleeding inside or potential for that, stabilize the patient, get them to a trauma center. DCAP BTLS, and this is something you're going to see a lot of, and now that we're doing this with trauma, you're going to be saying this as well when you do your trauma stations, when you do your trauma station for your national registry. When you're searching extremities, neck, chest, decap BTLS. Deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, laceration, swelling. So make sure you're actually saying this stuff in your sleep, because you're going to need to know this acronym, because if they are in a testing station, they're going to ask you, what does it mean? You need to know what you're looking for. So the nature of illness for internal bleeding is not always caused by trauma. Bleeding ulcers, bleeding from the colon, so we could have our upper and lower GI bleeds. Ruptured ectopic pregnancy can cause bleeding, and also aneurysms like a AAA and things like that, or an aneurysm in the brain itself causing bleeding into the brain. So it may not be a traumatic injury that causes this, but you need to do more of an assessment to kind of find out what's going on. So frequent signs for nature of illness for this here would be abdominal tenderness and guarding. So when you palpate the abdomen, is it rebound tenderness? Is it significant pain throughout? Is it rigidity? So as we're palpating, is it very hard to the touch? Your stomach should not be distended. If you're overweight, that's not distension. That's just being overweight. Distension would be that there's more fluid buildup in that free space, causing the abdomen to become distended and very rigid to the touch, and also significant pain. When older patients, some signs include dizziness, they start fainting or syncopal episodes, and increased weakness. Ulcers or other GI problems may also cause vomiting of blood or bloody diarrhea or bloody urine, which is why we need to ask patients that have diarrhea and things like that, did you notice any blood in your stools? Normally, you'll see darker blood in stools. It'll be like almost like a black stool, or they call it melena. Other one, vomiting of blood as well. If you have vomiting blood, you want to bring samples back. Stool samples are also very important as well, if you can get one, and bring it back from the hospital to be able to send out for what they call a fit test to actually check for stuff. Some signs and symptoms of internal bleeding, obviously pain is the most common. So pain management may be something of need. Swelling in the area of the bleeding, so you could have like a hematoma of some sort, any kind of distension. Dyspnea, so shortness of breath, tachycardia with hypotension. Those are your signs of your compensated shock. Hematomas and bruising as well. You could have bleeding from any body opening, whether it be oral, rectal, vomiting blood, melena, again, that would be bloody stools, pain, tenderness, bruising or guarding or swelling of the area or abdomen, broken ribs or bruises over the lower part of the chest, or a rigid distended abdomen. These are all signs of internal bleeding if you see this, which is why it's so important not just to palpate your patient on your assessment. You also need to expose your patient. You got to take off their clothing. You need to cut it off and look for it. Right? You'll be surprised of what things you can find after a motor vehicle crash if you do not expose your patient down to their underwear. Right? And even still, sometimes underwear needs to be cut off, depending if it's male wearing boxer shorts where you can't see underneath them. Right? You got to look for those types of injuries. There are times where patients have significant lacerations that have no bleeding. That's already clotted over. And you might miss that. That's one thing you don't want to miss going into a trauma center. Hypoperfusion or changes in mental status, weakness, faintness, syncope, or dizziness on standing, which is why it's good for us to do what they call orthostatic blood pressures from laying down, sitting up, and standing up. Changes in skin color or pallor or pale skin. Your later signs of hypoperfusion or shock would be tachycardia, weakness, syncope, dizziness at rest, thirst, nausea, vomiting, and a cold, moist, or clammy type skin. Some later signs of hyperperfusion also be shallow and rapid breathing, slightly dilated pupils or dull eyes, cap refill of more than 2 seconds in infants and children, weak, rapid, thready pulses, decreasing blood pressures or hypotension, and altered level of consciousness. So as we're doing our scene size up, we want to be alert to potential hazards, our scene safety, BSI, Vehicular crashes, remember to ensure the absence of leaking fuel and energize electrical lines. In violent incidents, make sure that police are on scene. The scene is safe for us to go into. We're going to follow standard precautions. We're going to determine the nature of illness or mechanism of injury, whether it be medical and or trauma. We're going to consider the need for spinal mobilization and additional resources as needed, and consider environmental factors such as weather. Do not be distracted from identifying life threats. Find them and treat them. Form a general impression. Note the important indicators of the patient's condition. Right? Look at them. Are they sick or not sick? Be aware of obvious signs of injury and determine the gender and age of the patient. The one thing about pediatrics, which we have not covered yet, is pediatrics can compensate like no tomorrow because they're so young. But when it's time for them to decompensate, they decompensate fast. Unlike an adult where you can see the decompensation through vital signs, with an infant, they may compensate very well with good blood pressures, good heart rates, and all of a sudden, boom, they drop. They drop quick. So be aware of your assessments. Perform a rapid exam. Remember, rapid exams, again, take no more than 90 seconds. Head-to-toe assessment, touchy-feely, right down through. If the patient has any obvious life-threatening external bleeding, address that first. Right? Apply tourniquet, apply pressure bandages, whatever is needed. If it's a small capillary bleed, you can pass on. You don't have to put a 4x4 over it. Keep going on your rapid assessment. Get that back on your detail. Assess your skin color and determine level of consciousness. Check for airway and breathing. So consider the need for spinal stabilization. Control the neck, C-spine. Ensure the patient has a patent airway. If the airway is not patent, then make it patent. Suctioning, whatever needs to be done within your scope of practice. Look for adequate breathing. If they're not breathing adequately, put a BVM on their face and help them breathe adequately. Whether they're breathing too fast or breathing too slow, we need to help them. Remember the normal ranges for your breathing rates. Adult is 12 to 20. Child is 15 to 30. Pediatric, 25 to 50. We're going to provide high flow oxygen or assist ventilations with a back valve mask or a non-rebreathing mask. We're going to insert an OPA if the patient is unconscious and does not have a gag reflex. If you apply the OPA and they have a gag reflex, take it out. Switch to a nasal airway, unless you notice any kind of facial trauma. Right? If there's facial trauma that's there, we cannot use a nasopharyngeal airway, especially when you have something like basilar skull fractures. We'll get into more of that when we talk about head injury. Circulation, assess the pulse rate, quality, and condition. Determine skin condition, color, and temperature. Check your cap refill times. Remember, 2 seconds is normal. Anything over that is too delayed. Control any external bleeding and treat for shock. Then we're going to make our transport decision by assessing the ABCs. Life threats will determine what our transport priority is going to be. Where are we going to go? If you don't know where we need to go, consult with medical direction, and they'll tell you. Signs that imply rapid transport, if they're tachypnic, which is fast respirations, or tachycardic, high heart rate, if they have low blood pressure, so a systolic blood pressure of less than 90, if they have a weak pulse and clammy skin, these patients need to be transported rapidly to the hospital. If the patient is considered critical and you can't bypass, the patient needs to be stabilized before they go somewhere else farther away, then you can go to a closer hospital, but also consider air medical transport. One of the things that we do around here, to kind of mention that, if we have a patient that is significantly critical, okay, we will call for a helicopter and we'll transport to the closest hospital. That way there, if the patient crashes along the way and the helicopter gets delayed or has to divert because of weather, at least we're already moving towards a hospital versus sitting and waiting on scene at the landing zone. So kind of keep this up in mind in your transport distances and all that. Always make your way towards a hospital if you can, because weather can change quickly and you might not be able to get a bird in the air. And that can change while they're mid-flight. Investigate the chief complaint. Look for signs of MOI and NOI and other symptoms that are there. Note obvious signs of internal bleeding and assess the entire patient. Remember, if you can't see it, you can't assess it, so you've got to expose your patient. Obtain a sample history, signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and events leading to the injury or illness. We also want to ask the patient about blood thinning medications. That's very important to make sure that they're not on blood thinners, or if they are. If the patient is unresponsive, obtain a history from medical alert tags or bystanders. Look for signs and symptoms of shock. Remember, tachycardia, hypotension, pale, clammy skin, altered mental status. Determine the amount of blood loss that is there, because the hospitals want to know, hey, roughly how much blood do you think they lost? And you got to make an estimated guess. Record all vital signs on your secondary assessment. If they're critical, it's 5 minutes. All right. If they're very critical, you may even do them over 3 minutes by putting them on auto BP. Depends. When the stable patients can do it every 15. Attach the appropriate monitoring devices. And with a critical injured patient or a short transport time, there may not be time to conduct a secondary assessment. You may be stuck on airway and never make it to doing anything else. If they're not on airway, they're going to die. So you might have to control that. Assess the anatomic regions for decap BTLS. Look for any uncontrolled bleeding from large scalp lacerations. Feel all 4 quadrants of the abdomen for tenderness and rigidity. And record your pulse, motor, and sensory. This is what they call PMS. I like using CSM. The last thing I want to do is to a woman is say, I'm going to assess your PMS today. They're not too happy about that kind of stuff. So CSMs, I like using them better than PMS. Looking at vital signs, assess vital signs to observe the changes that may occur during transport. Remember, a systolic blood pressure of less than 100 with a weak rapid pulse should suggest presence of hypoperfusion. Prehospital trauma life support uses the 90 for systolic pressure. AOS uses 100. We want to keep it right around that. Anything lower than that can cause more damage. Cool, moist skin that is pale or gray is an important sign to pick up as well, because that's poor perfusion. Then we're going to do a reassessment of this, repeat the patient in areas that showed abnormal findings. So assess the symptoms and signs of internal bleeding are often slow to present. So remember, unstable every 5, stable every 15, and keep looking at your patient after you've exposed them to see if anything changes during transport. The last thing you want is to do your first initial rapid trauma and detailed, and then you have a 20-minute transfer to the hospital and you don't look at their abdomen. Next thing you know, it's all discolored. Oops, I guess I missed something. That's an important finding to let the hospital know about. So make sure you're always looking at your patient reassessor, because things can change within minutes. Interventions for bleeding would be provide high flow 2 non-rebreather, 10 to 15 liters per minute. Control any external bleeding, whether it be through tourniquet and or pressure bandaging or just normal bandaging. Provide treatment for shock and transport. That's getting the patient warm, calling for ALS, getting fluids on board. And do not delay transport of a patient to complete an assessment. Get them going. Do it en route to the hospital. You're going to communicate and document everything that we do. So recognize, estimate, and report the amount of blood loss, how rapidly over what period of time it occurred. We're going to document all injuries, the care provided, and the patient's response to that. That's your reassessment part for the documentation from any kind of treatments or procedures that you may have done prior to. And we're going to communicate all this information to the receiving hospital. So follow standard precautions. Again, wear protection. You need to be protected from blood. Provide high flow O2. Make sure the patient has an open airway and patent with breathing and is breathing adequately. Remember, if they're not breathing adequately, fix it. BVM for the patient. Control obvious life-threatening bleeding as quickly as possible, because remember, we can't make more blood, right? We got to stop the bleeding and give them more fluids later on. We cannot make blood and give blood in the field. It has to be done through critical care medicine. There are several methods available to control external bleeding, whether it be direct pressure, even pressure, and even elevation. Pressure dressings and or splinting a patient, and tourniquets as well. We'll go over all that kind of stuff in a practical session on tourniquet application. Direct pressure is the most effective way to control bleeding. Pressure stops the flow of blood and permits normal coagulation to occur, start clotting. Apply pressure with your gloved fingertip and hand over the top of a sterile dressing and hold uninterrupted pressure for at least 5 minutes. And they talk about pressure, it's pressure. You got to hold it down, right? You can't just place your hand over it and call it good. You got to put some pressure on that. That's why I like pressure bandaging a lot better. This is your pressure dressing. Firm wrap of sterile, self-adhering roller bandage around the entire wound. Use a 4x4 gauze, then wrap around it. If it's a bigger dressing, we have 5x9s. We even have trauma dressings that we can utilize as well. Cover the entire site above and below the wound and wrap it tight. We're going to stretch the bandage tight enough to control bleeding. Remember, you should still be able to palpate a distal pulse. You don't want to make it too tight so they don't have pulses, but tight enough that it controls the bleeding. And we don't remove the dressing until a physician has evaluated. If it's bleeding through, apply more to the top of that. Just don't take it off. Just keep reapplying more and more. Hemostatic agents. This is a quick clot. Is any chemical compound that slows or stops bleeding by assisting with a clot formation. So the use of hemostatic agents in EMS remained largely experimental. Back when this was made, New Hampshire has approved it for BLS care. So you can use it on patients that require any kind of hemostatic agent. Tourniquets, useful in a patient who has substantial bleeding from an extremity injury. So several types of commercial tourniquets are available to you. Tourniquets are a phenomenal tool. Place it and keep moving. So if a commercial tourniquet is unavailable, you can also create one using a triangular bandage and some kind of object. I like using Yankauer suctions or whatever, but you can use a stick or a rod, whatever it takes. But we can take this and we can make our own tourniquets with this as well. Observe the following precautions, though. Do not apply a tourniquet directly over a joint, so above and below joints. And always place a tourniquet proximal to the injury site. You don't want to do it below it, but above it. Make sure the tourniquet is tightened securely, and never use wire, rope, or a belt or any other narrow material. You want it to be wide, so that it doesn't kill the cells and the vessels that are there. Place padding under the tourniquet if you can. Never cover a tourniquet with a bandage, and do not loosen the tourniquet after you've applied. Once it's on, it stays on. We don't take it off, right? Let the ERs handle that kind of stuff. Because they may need some kind of surgical intervention to help fix it. Splinting, we're going to do more of this. This is an air splint. It's a soft splint or any kind of pressure splints. This is going to control internal and external bleeding associated with any kind of severe injury. Because it causes pressure on the outside, pushing onto the wound itself. It also helps to mobilize fractures and act like a pressure dressing at the same time. We use only approved, clean, or disposable valve stems as well. Rigid splints will help immobilize fractures, reduce pain, and prevent further damage to soft tissue injuries. So once a splint is applied, monitor circulation in the distal extremity. That's why anytime we apply a splint, not just necessarily for bleeding, but for fractures, we have to check CSMs before and after, just like you've been doing all along. Bleeding from the nose, ears, and mouth. Obviously, there are several conditions: skull fractures, facial injuries, sinusitis, infections, use and abuse of nose drops, dried or cracked nasal mucosa. High blood pressure can also cause bleeding from the nose, coagulation disorders, and digital trauma. So extensive high blood pressure can cause significant nosebleeds. Keep that kind of stuff in mind. Epistaxis, another name for nosebleed, is a common emergency. We get called to those a lot, especially more seen in the ER than you are in the ambulance, but we do get called to those when they can't control them on their own. Occasionally, it can cause enough blood loss to send a patient into shock, because people can bleed quite a bit through the nose. Can usually be controlled by pinching the nostrils together. Never have a patient lean backwards, as we do not want the blood going down their airway into their stomach. It only takes about a tablespoon of blood into your stomach to have a reaction and start causing vomiting, which then in turn causes airway compromise as well. All right, almost done. Bleeding from the nose or ears also following a head injury may indicate a skull fracture. So we're going to look something for like what they call a halo effect. So it may be difficult to control. Do not attempt to stop blood flow from this. It's bleeding for a reason. It could be increased pressure causing blood to come out. So we don't want to stop it. Loosely cover the bleeding site with a sterile gauze pad and apply light compression dressing. And then a target or a halo-shaped stain may occur on a dressing or blood if you have cerebral spinal fluid. So you see the blood spot here, and you have that yellowish tint around it. That's what they call the halo effect. That means the patient's leaking CSF as well. So this usually requires surgery for internal bleeding or any kind of other hospital procedures. So keep the patient calm, reassured, as still and quiet as possible. Provide high flow to maintain body temperature. Remember, we want to keep them warm. And if they have an injured area, extremity, we can use an air splint to splint the injured extremity that's there for bleeding. All right, so let's go through the review and then we'll call it a night. So which of the following is not a component of the cardiovascular system? A, B, C, or D? Let's finish strong. Cardiovascular. That includes heart, veins, arteries. So the answer, wrong button here, is going to be B. Remember, the lungs are not part of the cardiovascular system. That's part of the respiratory system, right? So remember, it's the blood and all its components inside, from blood cells to plasma. All that's part of the cardiovascular system. Think anything that moves blood, right? It works in conjunction with the respiratory system. Number 2, perfusion is most accurately defined as A, B, C, or D. All right, a lot of C's. C is the answer. Number 3, the man involved in a motorcycle crash has multiple abrasions and lacerations. Which of the following injuries has the highest treatment priority? Perfect. D, arterial bleed. And number 4, which of the following sets of vital signs is least indicative of internal bleeding? Let's see some A's, B's, and C's. The answer is A. Hypertension, tachypnea, bradycardia. So choice A. When caring for a patient with internal bleeding, the EMT must first do what? One of the trick questions of this. The answer is D, appropriate PPE. All right, you have to take standard precautions first. This is one of the registry questions that will trick you up. Because the first thing you want to think about is obviously ABCs are controlling bleeding. But if you don't have standard precautions, you can't control anything. This is one of the questions that will throw you guys off in the National Registry. So the quickest and most effective way to control external bleeding from an extremity is all right, the answer is B. Direct pressure is the quickest way to do it. But again, apply pressure bandaging so you can move on with your assessment. Remember I mentioned before there's real world and there's what the book wants you to do. When applying a tourniquet to an amputated arm, the EMT should do what? Perfect. A lot of B's. The answer is B. 70-year-old man experiencing a severe nosebleed. When you arrive, you find him leaning over a basin which contains an impressive amount of blood. He has a history of coronary artery disease, diabetes, and migraine headaches. His blood pressure is 180/100, and his heart rate is 100 beats per minute. Which of the following is most likely contributing factor to his nosebleed? All right, a lot of A's. A it is. And number 9, when caring for a patient with severe epistaxis, remember that's a nosebleed, the most effective way to prevent aspiration of blood is to do what? Remember I mentioned we want to make sure the patient is leaning forward. So the answer is B. And number 10, controlling internal bleeding requires nothing we can do. So we require surgery in a hospital. All right. So I know that was a long night. Again, this will be up on the YouTube channel tonight. I'll put it up before I go to sleep tonight. Remember, make sure you guys are showing up for your clinical rotations. If you can't make it, let me know. There are some people that still need to schedule that, so let's get this stuff scheduled so we can get you guys passing this class at the end. Other than that, I will not be there Sunday. I have a guest instructor coming in for the day, and I will talk to you guys throughout the next week by phone to go over the remainder of the class and your grades. You guys have any questions for me at all?